That's not an accident. That's a brilliant design, which we'll go over in a little while. Well, Root, Orion, and Weed, like all good researchers, decide to make a graph. And arbitrarily, let's put supination on top, pronation on the bottom, and let's define the x-axis as neutral position, which of course represents time. They looked at the subtalar joint during the gait cycle, and here we've isolated the stance phase of gait. And you'll note that we heel strike in considerable supination. Let's combine their graph with the secret life of the subtalar joint that I just showed you. We heel strike in supination. The anterior facet is level. The momentum of the body comes down and hits a cone-shaped posterior facet. You want to rotate, but you can't. So you slide forward and medial toward the middle facet. You begin to load this middle facet and evert the heel. This happens very early in the gait cycle. Then you begin to slide down the tilted anterior facet, and right about here you fall off. What stops us from pronating? What actually stops us is a ligament. There's a spring ligament, or calcaneonavicular ligament, that goes from the sustentaculum tali to the navicular. And the head of the talus lands on it and acts as a shock absorber. It's important to absorb shock. Why? Some studies show we hit the ground with 1.5, 1.25, some up to 3 times body weight. How can you do that? How can you hit the ground with more than what you weigh? In physics, we call it impact or impulse. That means decelerating, slowing down as a function of time. For example, if you run your car into a mile of pillows, you decelerate very slowly. You don't have a lot of impact. Run your car into a stone wall. You decelerate very rapidly. You've got a lot of impact. And what have we covered the Earth with in the last 50 years? We've covered the Earth with concrete, which is a very high impact surface. Luckily, the spring ligament doesn't have to do it alone. During pronation, you bend the ankle, the knee, the hip. You use the entire lower extremity as a big shock absorber. If you don't absorb the shock in the lower extremity, it gets transmitted up the kinetic chain, the ankle, the knee, the hip, the lower back, the intervertebral discs. The question is, why do we go through this gyration 10 to 15,000 times in a day? Well, let me point out one of the great observations of Root, Orion, and Weed. They noticed that when the foot was supinated, when the arch was high, the foot would lock. And when the foot was pronated, it would unlock. Well, why do you want your foot to unlock soon after you hit the ground? The reason is Earth is an irregular surface. Every time you hit the ground, you don't know the shape of the terrain. So if you didn't have the ability to unlock your foot and become a mobile adapter or adjust to the shape of the terrain, every time you hit a clump of grass, you'd sprain your ankle. We'd have nothing but BAPS boards everywhere. This would be great for business. But that's not what happens. What happens is we adjust to the shape of the terrain. Then as body weight passes over the foot, we relock the foot to make it a rigid lever for propulsion. That lever has its axis at the ankle. And you're pulling on one side of the lever with the gastrocsoleus tendon, the Achilles tendon. And that creates a rigid lever for propulsion. So because the Earth is an irregular surface, every time we would hit a clump of grass, we'd sprain our ankle. We need this mobile adapter mechanism. But understanding the locking mechanism is really the key to understanding why people develop so many foot, ankle, knee, hip, and back problems. Now, Root, Orion, and Weed took a stab at it. Page 80, they write, parallelism between the long axes of the two articulations of the mid-tarsal joint increases total mid-tarsal joint range of motion, and obliquity decreases mid-tarsal joint range of motion. Let me translate that to English. What they're saying is, in front of the subtalar joint are two joints, the talonavicular and the calcaneocuboid. Together, those two joints make up the mid-tarsal joint. And what they're saying is each one of those two joints has its own axis of motion. And when those axes become parallel, you can get motion occurring. And when the axes go askew, no motion occurs. And this is what's taught in biomechanics, in podiatry school. You'll see it in chiropractic as well as physical therapy. And it's completely ridiculous. Why? You only need to open a talonavicular joint and look to see that it's round. In fact, Serafian, who wrote Functional Anatomy of the Foot and Ankle, calls this joint the acetabulare pedis, the acetabulum of the foot, the ball and socket. Back in 1930, a French anatomist named Capanghi did a beautiful diagram of the ball and socket nature of the talonavicular joint. Well, what do we know about a ball? Any axis that goes through the center of a ball is a valid axis for that ball. So the talonavicular joint, being a ball and socket, has an infinite number of axes. So whatever the axis is going to be at the calcaneocuboid joint, it will always find a parallel axis at the talonavicular. So the idea of axes going askew is ridiculous. So what is the locking mechanism? It's what I already told you. When the talar head slides down the anterior facet and falls off, you can now rotate around the cone-shaped posterior facet. It's a bony block. It's like falling off a cliff. Well, if you can understand that, you'll understand why so many people develop foot, ankle, knee, hip, and back problems. Because the vast majority of your patients and the vast majority of you watching this are pronators. In fact, there was a study done in Belgium that was presented at the John Weed Foundation meeting where they showed 95% of all people pronate excessively. 1% were ideal, and 4% didn't pronate enough. We call those the supinators. Well, how does the pronator walk? The first thing I want you to note is that the pronator generally heel strikes in less supination. What does that mean? It means that the anterior facet is not level. It's already tilted. So the momentum of the human body is not coming and hitting a level facet. You're not running straight into the wall. You're hitting a tilted facet. When you run into the wall at an angle, you bounce off at an angle. So what happens is you pronate earlier, faster, and deeper than you should. You try to recover, but at mid-stance, when the body weight is coming directly over the foot, instead of being near neutral position, you're coming over a pronated or unlocked foot. Now, coming over a pronated or unlocked foot 10 to 15,000 times a day creates biomechanical deformities that we call diagnoses. Let me make a distinction for you between a diagnosis and a symptom. You know what a symptom is? A symptom is when it gets bad enough, you're willing to pay money. In medicine, we start treating people when they take out their wallet. And then we discharge them when they put away their wallet. This is a huge mistake. We should be treating people long before they become symptomatic. We should be recognizing these deformities early and reversing them. And we should be treating them long after they become symptomatic.